Bismillah ar-Rahman ar-Rahim. Good day, everyone, and welcome to our series on hematological considerations in kidney transplantation. This content is a part of Core Curriculum 2025, and it builds on work of Lee and Dali and Jason Ifrit, two names you will recognize if you are following transplant, nephrology, and hematology closely. Now, before we dive in, I want to highlight something important. This topic isn't small, is not single lecture, it's not something you can cover and move on. It's a major pillar of post-transplant care, and it deserves a full deep dive. That's why we will be exploring this entire subject over 4 lectures, carefully step by step, because each piece of the puzzle matters. And today in part 1, we're going straight into one of the most common and clinically challenging issues after kidney transplantation, which is post-transplant leukopenia. We'll talk about why it happens, the major causes you should always consider, and the practical day-to-day decisions you need to make to manage it safely without compromising graft survival or patient outcomes. My name is Dr. Mahmoud Sheikh, nephrology consultant or Kidney Academy educator, and it's a pleasure to guide you through this series. And let's get started. Let's look at our first clinical case, which focuses on progressive leukopenia after kidney transplantation. This is a 56-year-old woman who developed gradually worsening leukopenia after 3 months after her transplant. She received anti-synuclein globulin as induction, ATG, and she's currently maintained on tacrolimus, mycophenolate, mofetil, and letermovir, prednisolone, and trimethoprim sulfamethoxazole. Her CMV viral load was undetectable just 2 weeks ago. Now, if you follow her labs over time, you will notice something interesting. Hemoglobin actually improves. Platelets remain fairly stable, but her white blood cell count steadily declines. She drops from 7.2 before transplant to 3.5 at 6 weeks, and then down to 2.5 and at 12 weeks. You can also see a fall in her neutrophil percentage, moving from 70% before the transplant to 50%, and later 45%. Meanwhile, lymphocytes remain low but unchanged. This pattern tells you she is developing progressive leukopenia, primarily driven by decline in neutrophils, and it's happening gradually over the first 3 months. That trajectory is important because it helps us to narrow the differentials and understand which medications or complications could be responsible. Now, here is the key question for this case. Which of the following is the most likely cause of her neutropenia? We have 5 possibilities to consider: ATG, letermovir, mycophenolate mofetil, tacrolimus, and lastly trimethoprim sulfamethoxazole. Before choosing an answer, we are going to walk through the timing, the mechanisms and interactions patterns, and what typically happens the first 3 months after transplant. Think through the medications, the expected trajectories, and which agent fits the pattern we just saw in her labs. And at the end of the discussion, I will reveal the correct answer. Now let's take a step back and make sure we are all aligned on what neutropenia really means in the post-transplant setting. Leukopenia is defined as the total white blood cell count of less than 3,000 cells per cubic millimeters. But the key isn't just the total number, it's understanding which specific white cell line is dropping. What matters clinically is the absolute concentrations of each subset, not just the percentage on differential. Among kidney transplant recipients, neutropenia is the most relevant. Depending on the study, anywhere from 20 to 63% of patients will experience at least one episode of after transplant leukopenia. And all of the forms of leukopenia, neutropenia is the one that consistently requires active, hands-on management. Severity is classified by the absolute neutrophil count. Mild neutropenia is between 1,000 and 1,500. Moderate neutropenia falls between 500 and 1,000. And the severe neutropenia is anything below 500 neutrophils per cubic millimeters. And here's the critical point. Once the ANC drops below 1,000, the risk of infection begins to rise, when it slips under 500, that risk increases sharply, especially in immunosuppressed transplant patients. This framework helps guide how aggressively we intervene. Starting with immunosuppression-induced neutropenia, which can be caused by induction medications like an ATG, almidozumab, and basiliximab. ATG will be produced by injecting human thymocytes into animals, not specific for T cells. It contains antibodies against different blood cell types, and it causes neutropenia primarily due to destruction of neutrophils. What about alemtuzumab? It's a humanized monoclonal IgG1 antibody directed against CD52. It causes slightly more neutropenia than ATG because neutrophils expresses CD52. And for basiliximab, it inhibits interleukin-2 mediated activation and proliferation of T cells, only acts on activated T cells, and rarely causes neutropenia compared to ATG and alemtuzumab. Going to maintenance immunosuppression and neutropenia, and starting from mycophenolate mofetil, MMF is the most common cause of post-transplant neutropenia, occurring in approximately one-third of transplant patients. It suppressed rapidly growing cell population, including bone marrow and gut epithelium, and it has dose and duration-dependent pattern, median onset 3 months after renal transplantation. It could be delayed onset due to cumulative effects and the higher steroid doses early post-transplantation, but it can take weeks to see full improvement if held anytime. One important note to be in mind, the use of concurrent medications such as valganciclovir and ganciclovir can exacerbate MMF-induced neutropenia. Now, let's walk through the practical algorithm for managing neutropenia after kidney transplantation. This is really the backbone of day-to-day decisions making, and it's where most of us spend time adjusting immunosuppression, checking for infections, and balancing safety with graft protection. We start with routine monitoring of CBC and differential. If the absolute lymphocyte count stay below 500 on 2 separate occasions without any signs of viral infections, then a clonal process has to be ruled out. And that's where flow cytometry becomes very important. From here, management depends entirely on the degree of neutropenia. In mild neutropenia with an ANC between 1000 and 1500 is often benign. This can be normal for some patients, especially those with Duffenol phenotype. These patients simply need ongoing monitoring. Moderate neutropenia with ANC between 500 and 1000 requires a bit more attention. This is when you check for CMV and EBV, and depending on the situation, you may need to consider valganciclovir or ganciclovir. If the neutropenia persists, the most common modifiable cause is MMF, in one word. Severe neutropenia and ANC below 500 requires immediate action. These patients need granulocyte stimulating factors to bring the neutrophils back above 1000, and at the same time you identify and treat the underlying cause. And very severe neutropenia, especially when ANC suddenly drops below 100, usually points toward immune-mediated destruction. This is often related to medications like trimethoprim sulfamethoxazole and less commonly rituximab. Once you reach the decision point, you have 4 management options. You can tolerate an ANC between 500 and 1000 and simply monitor closely. You can switch from MMF to an mTOR inhibitor. As long as there are no active ones, you can reduce MMF dose and add or increase prednisone. Or you can keep MMF at the same dose and give granulocyte colony stimulating factors once or twice a week to maintain an ANC above 1000 threshold. And remember, MMF adjustment takes time. It may take several weeks to see the full effect of dose reduction. This algorithm helps you to approach neutropenia systematically while keeping graft safety and infection risk in balance. Now let's look at how CMV and ABV fit into the picture we are managing neutropenia after kidney transplantation. The first step is straightforward. You test CMV and ABV viral loads. If CMV is detected, that usually gives you the answer. You halt, reduce, or replace MMF. You start treatment with valganciclovir or ganciclovir, and you give GCSF to keep the ANC above 1000. If CMV is not detected, you move to the next priority, making sure valganciclovir is actually dose corrected for the patient estimated GFR. Underdosing and overdosing are both common in early post-transplant period. If the dose isn't appropriate, you adjust it and reassess. But if the dose is correct, the next question is whether the patient has had CMV reactivation in the past. If they have, you simply continue valganciclovir If they haven't, you assess their overall CMV risk. High-risk patients stay on treatment or follow the high-risk pathway. Low-risk patients may be able to pause valganciclovir or step-down therapy depending on the clinical context. Now, if the problem is driven by EBV or instead of CMV, you follow EBV-specific management guidelines. That's a different pathway, but still essential because EBV viremia can contribute to bone marrow suppression. If neutropenia persists despite all of this, the most common modifiable cause is still MMF. At that point, you consider switching valganciclovir to letermovir plus acyclovir, and you closely monitor CNI and IMITOR inhibitor levels because letermovir interacts with both. And it's also important to remember that it can take several weeks for the marrow suppressive effect of valganciclovir to wear off. Ultimately, the algorithm helps you separate infectious causes from drug-related causes and to adjust therapy safely without increasing the patient's risk of rejection or uncontrolled viral replications. Now let's walk through 4 practical approaches to managing MMF-induced neutropenia. These are strategies we use every day in transplant medicine, and the choice depends on patient stability, their infection risk, and how far they are from the immediate post-transplant period. First, we sometimes tolerate mild neutropenia when the NEC is above 500. The risk of spontaneous infection is low, and if the count stays between 500 and 1000, that may still be acceptable, especially in patients who naturally have low baseline neutrophil counts, like those with Duffy-associated neutrophil count. Second, we can switch from MF to an mTOR inhibitor, such as sirolimus or everolimus. These drugs can also cause neutropenia, but through different mechanisms. We usually avoid this option very early after transplantation because of wound healing concerns, but it becomes reasonable after this time. Third, another opinion is to decrease the MMF dose and increase prednisolone. This may help stabilize the neutrophil count, although it's rarely a sustainable long-term strategy because of the adverse effects of steroids. And finally, we may choose to maintain the same MF dose and manage the neutropenia with intermittent G-CSF, typically once or twice a week. This approach is generally considered safe and tends to have minimal effects on overall immunity. Together, these 4 strategies give us a flexible framework to balance infection risk and rejection prevention when MMF causes neutropenia. Now let's take a closer look at the evidence behind MF dose reduction and why it remains a delicate decision in transplant care. When we look at the data on the risk of rejection, several studies, most notably by Zafrani et al. And Knoll et al., show that holding or reducing MMF can significantly increase the risk of acute rejection. One key threshold that stands out is the 6-day mark. When MMF was held for more than 6 days, the rate of acute rejection rose sharply, and even dose reduction alone, when done because of side effects, was associated with shorter time to the first episode of acute rejection. Remember also that any episode of acute rejection is strongly linked to shortened allograft half-life and the development of chronic allograft nephropathy. Now, shifting to the expert consensus, a 2023 panel of 14 transplant experts reviewed the available evidence and interestingly couldn't reach agreement on single preferred strategy for managing MMF-induced neutropenia. What this tells us is that there isn't one universal answer. Instead, there are multiple viable strategies, each of which may be the right choice depending on the clinical context. And that context depends heavily on 4 major considerations: the patient's immunological risk, which is very important, the severity of neutropenia, how much, the number, and whether there are concurrent infection or not, and the range of patient-specific factors. So rather than one fixed recipe, managing MMF dose reduction is really about balancing risk and protecting immunity without compromising graft survival, which is very important. Let's talk about Duffy-associated neutrophil count, or DANC. This is an important concept, especially when we evaluate post-transplant neutropenia in patients from certain genetic backgrounds. Duffy antigens are normally glycoprotein chemokine receptors, but a single nucleotide variant in the DARK or ACKR1 gene can prevent Duffy expression, creating what we call the Duffy null phenotype. This phenotype is particularly common in individuals of African or certain Middle Eastern ancestry. Clinically, patients with DANC tend to have lower baseline neutrophil counts, and because this is genetically driven, they are less likely to show improvement when we adjust immunosuppressive drugs. Despite the lower counts, the risk of infection isn't high as you might expect because this neutropenia is constitutional rather than acquired. For that reason, in these patients, it may be quite reasonable to tolerate mild neutropenia as long as they are stable and clinically well. The key point here is simple. Always consider the patient pre-transplant baseline neutrophil count before labeling post-transplant neutropenia as drug-related or high risk. Now let's talk about azathioprine and neutropenia. This is a drug we don't use as often today, but still appears in transplant practice, so we need to understand exactly how it behaves. Starting with background, azathioprine is an inhibitor of purine synthesis. For years, it was the main antimetabolite used in kidney transplantation until MMF became the preferred option, mainly because it showed a clear reduction in acute rejection rates compared with azathioprine. Moving to the mechanism, just like MMF, azathioprine tends to cause dose and duration-dependent neutropenia. The drug is converted into 6-mercaptopurine, and that step is controlled by enzyme TPMT, thiopurine S methyltransferase. If the PMT activity is low, more of the active metabolite accumulates, and that's where toxicity shows up. Eventually, the pathway leads to inactive metabolite, but the bottleneck happens earlier. So the idea is one line: azathioprine convert to 6-MP, inhibits de novo purine synthesis in activated lymphocytes, reduce clonal expansion of alloreactive T cells, and ultimately decrease cell-mediated rejection in kidney transplantation. Now about risk factors. Patients with intermediate TPMT activity are at high risk for myelotoxicity. That's why TPMT genotyping helps us to identify patients who may need dose reduction right from the start. Finally, drug interactions. Certain medications can dramatically increase myelosuppression. The big two are allopurinol and febuxostate. Both of them inhibits the metabolism of azathioprine, leading to higher levels of 6-mercaptopurine. So the risk of neutropenia shows up. Whenever these drugs appears in a patient chart, you either reduce the azathioprine dose significantly or avoid the combination entirely. And that's the overall picture of how azathioprine works, why neutropenia occurs, and what increases the risk. Now let's shift to viral infections and neutropenia, because in transplant medicine, these infections shape a huge part of our post-operative landscape. Starting with cytomegalovirus, this is herpes virus with seroprevalence ranging anywhere from 30 to 97%. It's still one of the most common opportunistic pathogens we deal with, and a major contributor to both morbidity and mortality in solid organ transplantation. The mechanism is pretty interesting. CMV drives neutropenia by releasing inhibitory cytokines that interfere with neutrophil development inside the bone marrow. So when you see a transplant patient dropping their ANC, CMV should always be on your short list. And the highest risk group is clear. CMV seronegative recipient receiving an organ from seropositive donor, our classic D positive R negative scenario. This mismatch carries the strongest risk for significant CMV disease and for associated neutropenia. Now moving to EBV virus, which can also cause neutropenia, usually mild, but every now and then it becomes clinically significant. Risk climbs sharply in patients who are EBV naive, meaning the donor is EBV positive, while the recipient is EBV negative, like CMV, as we mentioned before. The major complications here is something we all fear in transplant medicine: post-transplant lymphoproliferative disease, PTLD. It is potentially fatal complications, strongly linked to EBV replications under high immunosuppression dose. Neutropenia with EBV can come directly from infection itself or occasionally from the therapies we use. For example, rituximab when we are treating PTLD. So both CMV and EBV can suppress the marrow, but each dose so through a slightly different biological pathways. And recognizing the risk profiles helps you get ahead of the problem rather than chasing it later. Now let's walk through valganciclovir and neutropenia, because this is one of the biggest contributors to cytopenias in our transplant patients. First, the mechanism and overall risk. Even though CMV infection itself can cause neutropenia, the primary culprit in most cases isn't the virus. It's actually the antiviral therapy we use to treat or prevent it, mostly ganciclovir or valganciclovir, and the risk is not small. Prophylactic valganciclovir carries an 8 to 13-fold higher risk of neutropenia compared with patients who receive no prophylaxis. So when someone on valganciclovir develops a sudden drop in neutrophils, you are already on the right track. Now, how it works. Ganciclovir is a guanine nucleoside analog. It gets converted into an active triphosphate form, and that form inhibits CMV DNA polymerase. But it doesn't stop there. It also inhibits mammalian DNA polymerase. That's why we see dose-dependent and duration-dependent myelosuppression. It's trade-off, strong antiviral activity, but collateral damage to the bone marrow. Let's shift to dosing consideration. Vancomycin was designed to overcome the poor oral bioavailability of ganciclovir. Once absorbed, it gets hydrolyzed into ganciclovir, which is completely renally cleared, and this part is critical. If vancomycin dosing is not properly adjusted for estimate GFR, hematological toxicity becomes much more common. You will see neutropenia, anemia, thrombocytopenia, the whole picture. At the same time, reducing the dose below the recommended eGFR adjusting level is almost never a good idea. When you underdose, you weaken efficacy and open the door to resistance. So valganciclovir requires this delicate balance, not too high for toxicity and not too low for failure. And that's the key clinical reasoning behind valganciclovir-induced neutropenia. Now let's talk about letermovir, which is becoming a very important alternative to valganciclovir, especially when you are trying to avoid neutropenia in post-transplant patients. Starting with mechanism of action, letermovir works by inhibiting the CMV DNA terminase complex, a completely different target that polymerase pathway used by ganciclovir. Because of that, it has no activity against herpes simplex virus or varicella zoster virus. So when you use it, we usually pair it with acyclovir to cover those gaps. The real attraction is the key advantage. Letermovir doesn't cause myelotoxicity at all, and that alone makes it a game changer for patients who are struggling with valganciclovir-induced neutropenia. There is also no dose adjustment required in kidney transplant, which simplifies management dramatically, especially in kidney transplant patients. And importantly, there is no cross-resistance with other CMV antivirals, because it hits a different part of the viral machinery. But we can't forget the drug interactions. Letermovir significantly raised the level of several immunosuppressive medications. Tacrolimus goes up, cyclosporine goes up, and mTOR inhibitors goes up as well. So anytime you start letermovir, make sure you are adjusting and monitoring immunosuppressant trough level closely. Now in clinical use, letermovir is approved for prophylaxis of CMV infection, but not the treatment. And that distinction matters because if you try to use it off-label for treatment, resistance can develop very quickly. We reserve it strictly for prevention in the right setting. One of the key studies from Limay and colleagues showed that letermovir was non-inferior to valganciclovir for CMV prophylaxis, but without the hematological toxicity. That's why many centers are now turning to it, especially for high-risk patients who simply cannot tolerate valganciclovir. So overall, letermovir gives us a clean, targeted antiviral with fewer marrow effects, but it requires smart immunosuppressant monitoring. Now let's move to management strategy when neutropenia intersects with CMV risk. That is where clinical reasoning really matters because the right decision changes depending on which risk strategy the patient falls into. We'll break it into three groups. Number one, low risk CMV risk, the D negative or negative group. Here we have some flexibility. It's reasonable to hold valganciclovir and monitor CMV viral loads weekly with a preemptive strategy. Or you can switch to letermovir, especially if the neutropenia is clinically significant. Both approaches are acceptable in this low-risk population. Number two, high CMV risk, the D positive or negative group. This group has the highest risk of CMV disease, so we need consistent prophylaxis. In the setting of neutropenia, it's reasonable to switch to letermovir for prophylaxis. This allows you to preserve protection against CMV while avoiding the marrow toxicity of valganciclovir. And number three, patient with prior CMV reactivation. Here is the priority shifts. In most cases, valganciclovir should be continued because these patients have already demonstrated susceptibility to active CMV. And instead of stopping the antiviral, we support the marrow. You can use other modalities like GCSF to raise the neutrophil count and allow antiviral therapy to continue safely. Finally, an important note, the efficacy of letermovir during active CMV reactivation hasn't been fully addressed in clinical trials. So at that point, we consider letermovir a prophylactic agent not a treatment agent. This structured approach helps you to choose the safest and most effective option based on each patient's CMV risk profile and hematological tolerance. Now let's look at trimethoprim sulfamethoxazole or TMP-SMX, a medication every transplant patient receives, and one that occasionally complications that feature with neutropenia, starting with the mechanism. TMP-SMX can cause neutropenia, but usually through an idiosyncratic immune-mediated mechanism rather than pure myelosuppression. So its direct myelosuppressive effect is actually quite limited, and that's supported by randomized trials showing very little hematological toxicity. So when neutropenia appears, TMP-SMX is usually not the sole culprit. In terms of clinical use, trimethoprim is our frontline agent for pneumocystis jirovecii, pneumonia, prophylaxis. It's extremely effective, inexpensive, and protect against multiple infections, which is why we try to keep it on board whenever possible. Now, the management controversy. Different transplant centers handle this differently. Some centers hold TMP-SMX when patients develop severe neutropenia, others continue it, because in many centers and many cases, other factors like valganciclovir and MMF or underlying CMV as much more likely be the contributing factors. So the decision often depends on the clinical context, not the drug alone. Let's talk about the distinguishing features of TMP-SMX related neutropenia because they help separate it from valganciclovir or MMF toxicity. When this happens, it's usually rare but very immune driven. The onset is sudden, very acute, not gradual, and the severity tends to be significant, not your mild to moderate drop. And the pattern is very sharp, sudden fall in neutrophils, rather than slowly progressive decline you see with other agents. Recognizing that pattern immediately narrows the differential. Finally, the alternative, when TMP must be stopped, atovaquone is the most commonly used substitute, but it comes with trade-offs. It's more expensive, it tastes worse, and can be less effective unless the patient takes it very consistently. So whenever you discontinue TMP, you need to weigh the pros and cons carefully. Overall, trimethoprim remains a cornerstone in transplant prophylaxis, and neutropenia management requires a balanced contextual approaches. Now let's look at the typical patterns of drug-induced neutropenia, because recognizing these trajectories in real time is incredibly helpful in transplant practice. On the graph, we are following the absolute neutrophil count over time after starting different medications. The first line is a purple line, represents an antibiotic that causes an idiosyncratic immune-mediated reaction. Notice how the neutrophil count stays completely stable for weeks and then suddenly crashes. There is no gradual decline, no warning. It's an abrupt drop straight into the severe neutropenia range. That pattern is classic for drugs that trigger immune destruction, like some beta-lactamase, lactams, or trimethoprim in rare cases. Now look at the blue line, representing MMF. This is a very different pattern. Instead of sudden crash, you see slow progressive decline over many weeks. The count drifts downward, 4, 3, 2, eventually crossing into moderate and then severe neutropenia. This reflects the classic dose and duration-dependent myelosuppression you see with MMF and other anti-proliferative agents. These two patterns matter clinically. A sudden drop suggests an immune reaction and often requires stopping of the offending drug immediately. Gradual decline points to cumulative myelosuppression, which means dose adjustment, supportive therapy, or switching agent may be enough. And the threshold on the left, mild, moderate, severe, guide how aggressive we intervene. So when you are following transplant patients and you plot their neutrophil trajectory, the shape of the curve often tells you more than the absolute number. Now let's talk about when we should involve hematology. This is very important because most neutropenia in transplant patient is drug-related and reversible, but there are moments when you need a specialist eye on the case. The first category is persistent severe neutropenia, especially when it's accompanied by symptoms. Think about patients who develop early satiety, discomfort or pain in the left upper quadrant, or a palpable spleen on examination. Those patients should raise concern for splenomegaly, and the action here is straightforward. You obtain abdominal imaging to evaluate the spleen size. If splenomegaly is confirmed, hematology referral is appropriate. The second scenario is splenomegaly after kidney transplantation, and this one is subtle. In liver transplant patient, persistent splenomegaly is common even when portal pressure normalizes. But in kidney transplant patients, splenomegaly is not typical at all. When you see it, it deserves hematology evaluation to rule out infiltrative or hematological causes. The third point is nutritional deficiency testing. We often see folate, B12, and copper levels orders in the workup, but their yield is extremely limited when the patient is eating normally and has a functioning GI tract. These deficiencies almost never present with isolated neutropenia. Folate deficiency and copper deficiency both are quite rare in this context, so while it's common to check them, they shouldn't distract you from the more likely causes. So in summary, persistent severe neutropenia with symptoms or unexpected splenomegaly in kidney transplant patients and rare nutrition deficiencies that only apply in very specific scenarios, these are the times when hematology should be stepped in. Now let's look back to our question. The correct answer is MMF. The key clue from the case is the timeline. The neutropenia didn't appear until about 6 weeks after transplantation, and then it gradually became more severe over time. That slow progressive decline is classic for MMF. It's dose dependent, it's duration dependent, and it develops over weeks, not suddenly. So let's go through why the other options are less likely. ATG can definitely cause neutropenia, but the pattern is very different. It typically happens acutely, right after transplantation, when the medication is administered not weeks later. Letermovir doesn't cause neutropenia at all, so it's off the list immediately. Tacrolimus can rarely lead to idiosyncratic neutropenia, but those cases are uncommon, and the pattern doesn't match this patient's slow progressive drop. It's far less prevalent than we see with MMF toxicity. And finally, trimethoprim sulfamethoxazole. When it causes neutropenia, as we mentioned, it's immune-mediated, very acute, very severe, and within sudden drop. Completely the wrong timeline for what we are seeing here. So putting it all together, the timeline, the pattern, and the mechanism, the best answer is MMF, as we mentioned. Before we wrap up today's session, I just want to thank you all for being here throughout this lecture. Your curiosity and attention are exactly what pushed our nephrology community forward. If you found today's discussion valuable, feel free to stay connected with us across all platforms. You can simply scan the QR codes on the screen to follow my Facebook page, subscribe to YouTube channel, and join me on X at Nephron Tips handle for daily updates, clinical papers, and new cases. And for those who want deeper learning, structured notes, and MSQs, OSPE practice, and advanced discussions, our Telegram study groups are always open for you. These groups are designed to support fellows, residents, and anyone preparing for exams looking to sharpen their clinical reasoning. This series is just getting started. In our next lecture, we'll move into other blood disorders after kidney transplantation, diving deeper, comparing mechanisms, and exploring real case decisions making. Thank you once again for your time and your energy and your commitment for learning. I'm Dr. Mahmoud Sheikh and look forward to seeing you all in the next sessions. Thank you so much.